Hi, everyone, and welcome to the Service Design in Health Research webinar, which is hosted in collaboration between the CIHR Institute of Musculoskeletal Health and Arthritis and the Institute of Health Services and Policy Research. The aim of this webinar is to share some strategies and considerations for improving research design and fostering meaningful collaborations with scholars and practitioners from other academic disciplines, such as design and the social sciences, as well as with underserved, marginalized, and oppressed communities. I'm Alex Haagaard. My pronouns are they, them, and I will be your facilitator today. Before we dive in, I want to take a moment to acknowledge that I am joining you from the stolen land of the Huron-Wendat, Anishinaabe, and Haudenosaunee peoples, which is colonially referred to as Kingston, Ontario. If you feel comfortable doing so, you can share your own land acknowledgements in the chat. During our preparatory call for this webinar, the topic of being a troublemaker came up a few times, and we realized that we wanted this webinar to be a safe space for troublemakers. To that end, before I continue, I also want to acknowledge that I increasingly have trouble with land acknowledgements. I have read the words of Indigenous people who have pointed out that very often they are a way of making settler speakers and audiences feel like we are doing something to address the violent history of the country we participate in and benefit from as settlers, when materially, practically speaking, we usually aren't doing very much at all. I agree with them. I agree with the principle of no land acknowledgement without land back. Speaking about a wrong that has been done, that is ongoing, without taking material action to undo that wrong, perpetuates it by making people more comfortable with it. It gets worse when we speak about the wrong in a way that neutralizes it, such as when we say ancestral and unceded rather than stolen and occupied, such as when we acknowledge land rather than genocide, and such as when we acknowledge settler colonial genocide as something that occurred in the past and not something that is ongoing and continues to be supported by our society. This critique of land acknowledgements is, in a roundabout way, what led me to propose this webinar to CIHR, IMHA, and ISPER. Over the past 2 years, I've been struggling to access not just diagnosis and treatment, but belief and care, in the most basic, non-medicalized sense of that word, for a new and profoundly debilitating constellation of autoimmune symptoms. And it's had me wondering, what really is the point of any of my patient advocacy or design? When I sit in meeting after meeting talking about the importance of health equity and the violent psychologization that marginalized patients face when their illness doesn't make itself visible in the ways clinicians require it to believe in it. And the people in those meetings nod along and talk about how what I'm saying is so important, and yet no one ever really does anything about it. I never get taken more seriously or treated better as a fat, queer, autistic person whose physical illnesses somehow just never seem to show up on blood work or imaging, who grew up in rural Ontario, and who has never had anyone to advocate for me in medical appointments to make healthcare providers believe it's worth caring about me because there's visible proof sitting in the room that at least one other person in the world will fight to protect me. And at a certain point, it clicked for me that more often than not, we treat social determinants of health the same way we treat land acknowledgements. They are something we talk about in neutral, abstract terms, taking care to avoid saying things like medical misogyny and racism and ableism and social murder, and doing nothing to address the root of the problem. And so this webinar is my effort to start doing something about them. I am hoping this webinar gives health researchers some tools to start thinking about how to intervene in social determinants of health and to recognize that acknowledging injustice without acting against it just isn't enough. Health justice and land back are two sides of the same coin. So now, a few housekeeping notes. Please use the Q&A function to submit your questions for our speakers. If you see a question that resonates with you, feel free to give it a thumbs up. This helps prioritize the most common inquiries. We'll do our best to answer as many questions as we can during the session. Closed captioning is available. To enable it, simply click the CC button at the bottom of your screen. Translated captions are also available, which you can find with the same CC button. And now we'll get to the main show. I would love for each panelist to provide a brief introduction. Just tell us a little bit about who you are, what areas you work in, and why you're here today. I will start with Diane, who's at the top of my screen.
Thanks, Alex. Hi, Diane Finegood. The journey's been a long and winding road, including having served as an inaugural scientific director for the CIHR Institute of Nutrition, Metabolism, and Diabetes. I'm now nearing the end of my so-called academic career and still find myself, even though it was 25 years ago I was appointed to CIHR, thinking about how we do health research, how we fund health research, how we value it. So I think that's why I'm here, along with the fact that my favorite passionate topic is that that we need to use system thinking because of the complexity of many of the healthcare issues that we face. So have you asked for my takeaway? My takeaway is complex is not the same as complicated. Everybody should be able to remember that, and I'll explain later why I think that's important. Thanks, Alex.
Amazing. Thanks so much, Diane. I will throw to Isabel next.
Thanks so much, Diane and Alex. So I'm Isabel Jordan, and I feel it's really important to talk about where I live and what my positionality. I'm in the stolen lands of the Squamish people, more commonly known as Squamish, BC. Um, I've taken lately to doing a couple of things because of the same reasons that Alex was speaking about with land acknowledgements. And one is really reflecting on how I've benefited from the continual uh, looking after the land and the culture here by the Squamish people. And I really want to think about, and I'm really grateful for the fact that through my kids' school and through community learning opportunities, I've been super fortunate to be able to learn from Squamish educators and elders, and am continually just really grateful for the fact that they're willing to help us into their culture and understand what their needs are and what's going on. There's like a fabulous DJ from the Squamish Nation here right now. And also that, they're them curating this land. My life is hard, my life is stressful. And the ability to be able to go into these woods and go onto the water and find some peace is just super special. The other thing that I do in recognition of land back is every time I make a land acknowledgement as a speaker, I make a donation to the local Squamish Lillooet Museum because of the wonderful work that they do. So my positionality, I am an old white lady who is disabled. And I'm also a parent to two young adults who themselves are disabled. I've done a lot of patient partnership work, which means bringing my lived experience to health research, and a lot on medical trauma and shared decision making, and also pediatric pain, all kinds of stuff that has to do with really harms that have happened to our family and to me. But I'm also an advisor and a patient lead in patient partnerships, so how to do that kind of work in a variety of roles. The takeaway I have is the takeaway I always have, which is patient partner expertise is different, but equal to other experts on a team. But respecting that through language and action is how we bring that vital information to decision making, because it's largely been absent. So we really need to think about it, but we also need to have actions.
Thanks for sharing that, Isabel. And finally, I'll pass to Michelle.
Great. Thank you so much for having me here today. It's a pleasure to be on this panel and to talk about these areas of research in health research. I'm Michelle Wyndham West, and I'm the Graduate Program Director for the Inclusive Design and Design for Health MDes programs at OCAD University in downtown Toronto. I'm trained as a medical anthropologist, but I've been doing co-design and I've had a chance to really reflect on the practice of co-design. So I'm now calling it critical co-design. For many years, it's something that has its roots in anthropology for me, community-based research. And I do research amongst different topic areas, but one that I've spent the most time on, which is very near and dear to my heart, has to do with low-income older adults or seniors who have experienced housing instability and homelessness, and doing co-design with them. So thank you for having me.
Thanks so much, Michelle. Okay, so for our first question, in health research, a lot of time, money, and effort are spent studying and talking about structural or social determinants of health. I kind of use the term structural and social determinants of health interchangeably. I think social determinants is more common, but I like structural because it gets, I think often social tends to be interpreted as psychosocial and thus as psychological slash behavioral. So I like structural because it really gets at that sort of systems thinking route that Diane has already mentioned. But at any rate, a lot less time seems to be spent on actually building, testing, and implementing interventions to address these determinants. So I'm curious, Isabel, in your experience or opinion, what are the key factors that limit how health research as a field seems to respond to social determinants of health?
So I'm going to go very much just from my perspective as a non-academic, as a person in the community, as a parent, as a disabled person, and as somebody who tries to figure out what best practices look like in patient partnership. And one thing that I think is really kind of blocking progress in this area is understanding what exactly the expertise is that people like me bring to health research. One of the things that I hear over and over again in terms of um, why have patient partners there is that we are experts in our own bodies and our own diseases. And of course, that's true. That should be a given. But that expertise isn't limited to that. We are navigating systems of care, systems of health, a society that's incredibly ableist, and navigating those barriers and those harms that are entrenched in all of these systems. And that's one of the things we really bring that I found researchers have been surprised by, that we have kind of this overall view of how these things can interact and these systems can interact with one another. And I think, patient partnership is happening more and more, but it, often looks like me, middle-aged white ladies. And that's not good enough. Because if we're trying to make these systems work together, if we're trying to make health research that's effective, we really need to find ways to learn from the folks that have the most barriers. And I'll say, like, lots of stuff went bad for me. I have, and my kids we continue to have many, many barriers in the system. But there are others who have different ones or more with intersectional identities. And if we ensure that we're also working with folks like that with these different identities, I think if we or if we work with people that have the most barriers, it'll make it better for people with the least barriers as well. We're going to make the whole thing better. There's too many people. I think a lot about pediatric pain stuff because that's an area I work a lot in. And, the people in general, kids aren't benefiting from research in pediatric pain for a lot of systemic reasons in the system, but racialized kids, disabled kids, kids with rare disease, they benefit even less, which is like super appalling because it's not great out there. And to find ways that we can bring in that knowledge into health research so it is effective, so it is addressing the real issues that are barriers to people, is we need to understand how to make that happen in ways that are safe so that we can have access to that knowledge. Does that make sense? It's kind of blah, blah, blah.
That makes total sense to me. Diane, I'm curious, you have experienced health research as a researcher, as someone navigating it on your own behalf, as a researcher across disciplines, and also as a funder. So I'm curious, from all of those different perspectives, what are the key barriers that you've seen to this kind of response to structural factors?
So, with the benefit of hindsight, I would say that I'll just reiterate my key message, which is that complex is not the same as complicated. And what do I mean by that? Well, complex challenges like the ones our health system face are unpredictable, self-organizing, and emergent. And I know that's lingo that some people may not find accessible. But if you think about complicated challenges as being predictable, controllable, and designable for, you can quickly start to see that many of the methods we've developed in health research and are trying to apply in service delivery pretend that the system is just complicated, not complex. And for those who might want an even more accessible way to think about this, simple problems are baking a cake. Complicated problems are sending a rocket to the moon. You can do it repeatedly. You got to do a bit of trial and error to get all the parameters right. And complex problems are like raising a child. And as we know, as Isabel has pointed out, this is a very complex issue. So why is that important? Well, it's important because there's some things that we know about complex problems that don't apply to complicated problems, like that, the idea that we could find the solution in the causes. So even the language, social and structural determinants of health, implies that we should figure those things out, find those associations, and address those determinants. But if we hit it head on, we're going to keep doing the same wrong things, in my opinion, over and over. If we respect these problems are complex and we're not actually going to focus exclusively on the determinants, then we start to ask questions like, well, what works in a complex situation? And there are theories of complexity. One of my favorites is the complexity theory of outcome creation, lofty name, but it says stewardship, coordination, adaptation, learning, partnership. Those are the features of getting out of or reducing the complexity of a particular situation. So having been a funder and all of those things, I really think that we need to start using some of these frameworks that articulate complexity as the tools in which we design, implement, and even evaluate health research. So, we've done great with the biomedical research. We've kept people with medical complexity alive for a long time, but we don't take care of them in ways that the system understands. There is an individual here, there is a person who has more expertise in their own experience than you do. And as Isabel points out, you have to be listened to both in terms of designing health research, but also in terms of your own health and the health of your family. So I've probably gone on too long, so I'll stop there unless there's somewhere else you want me to go.
No, you are perfect. You are all doing an amazing job at keeping time. And I want to circle back later to that idea of how we can and how we need to address problems, not by coming at them head on, because this is, I think, one of the things I've observed within my own design work and advocacy. And I think, if editorializing a little bit here, I think one of the biggest challenges that I've observed in terms of taking up designerly ways of thinking and doing within health research. So leading into that, Michelle, I'm curious what your thoughts are on why health research needs or could benefit from interdisciplinary perspectives for effectively addressing structural or social determinants of health. And what disciplines do you draw from in your own work, on some of the methods or conceptual frameworks that are most important to you?
That's a really good question. I would have to say I go back to my training in medical anthropology. So I have a master's in cultural anthropology, but a PhD in medical anthropology. And there's a framework by two very well-known medical anthropologists, Nancy Shepherd Hughes and Margaret Locke, who've since retired but did amazing work. And they have a concept, I think it was published in the 80s. That's how old it is, but maybe in the 90s. I would have to be corrected on that. And it's called the three bodies. And I find it works really well as a metaphor to describe how the different areas of society work together. So you have the body politic, the social body, and the individual body. And I think when you look at those and how they work together, and sometimes they come into relief, sometimes they go into the background, that is a holistic way of looking at these connections. So the body politic would be the political lay of the land, the institutions, the law, the regulations, those types of things that are out there that you have to abide by, whether it's a medical system or a housing system or whatever it may be. And then the social body reflects the social mores or the values and customs and beliefs at the time. And so, those can be highly gendered, they can be classed, they can be, age related, but they also work on a symbolic level, right, as well. And then you have the individual body, which would be the individual person's experience. So what I like to do when I do co-design is map out the three different types of bodies and then the relationships between them. And I find that if one can map out the social body and the political body and then trace people's lived experiences through those, that's a really good way of providing a holistic sort of 360 view and looking at problems in a new way with a new light.
Amazing. Thanks for sharing that. Throwing back to you, Diane, I'm curious about the methods and frameworks and disciplines that you tend to engage with.
So I put a link in the chat to this idea of the complexity theory of outcome creation, and I'll put another link into a whole bunch of different frameworks for systems thinking. So from my point of view, I think we need to start with the acknowledgement that something is complex, and that means it's unpredictable, self-organizing, and emergent, and then begin to think of approaches that actually address some of that complexity and try to reduce it. Building trust is something, language I use, but what Isabel's talking about in terms of building a relationship with the individuals that you're working with as co-researchers, like some individuals call them. Building trust is a process of reciprocity where both sides gain. There's gratitude expressed, there's mutual self-interest. So there's a bunch of these kinds of ways of acting and being, ways of thinking that we need to adopt and begin to recognize that not all health research is a reductionist exercise where we work out the causes of the problem and then we know where the solutions are. And so that's kind of where I push into. I feel like I'm repeating myself and not answering your questions. So maybe I'll stop and let you penetrate further if you want.
Yeah, no, I think let's go back to sort of the idea of not coming at problems head on, because I think
Yeah.
that is really a crucial piece. I'll let you speak to I'll let you speak to it more than ranting on and on, but I think that's really a crucial piece to addressing.
So I think one of the things that's important is that we recognize there's different kinds of complexity. There's lots of complexity in things. So in this website, there's a framework called the 4 dimensions of complexity, and it talks about compositional complexity, which is something's made up of a variety of different actors or organizations, pieces, and that can create complexity. There's experiential complexity. That's something that Isabel is talking about in terms of, in her experience, her life and her helping guide her children through life is their experience of the complexity of the system. So they experience complexity all the time. There's dynamic complexity. We can think about climate change and some of the things that are happening there as a dynamic circumstance, or we can embrace the fact that we can influence what emerges out of a system through a dynamic intervention, like building a community of practice or something like that. So there's a kind of a not head on. I'm not so. I have a community of practice that I run right now for individuals who are interested in changing the systems that we have as it relates to palliative care or the palliative approach to care for people with neurodevelopmental disability. So those are two systems that don't know each other hardly at all. And so if you were going to try to go at that head on, I'm not even quite sure what you would do other than maybe write a bunch of policies that will never get implemented or study the problem for a long time. And so we went right at it and said, let's just bring people together so that they can build connections. And another framework in the website is something called 6 Conditions of Systems Change. It's about things that are explicit, policy, practice, resources, about things that are a little less explicit, like power dynamics and relationships and connections, and even more hidden or implicit are our mental models. And so we tend to ignore the mental models. We often ignore the power dynamics and the relationships piece, and we go right at those things that we can see and policies, practice, and resource. But if you don't deal with the others, then you won't get there. So building relationships is a good strategy. Feels like it's indirect, but it's a good strategy to evoking change in the system. And we need to study how we do that, how we influence relationships and power dynamics when we bring in an intervention like creating a community of practice. Does that get at what you're asking, Alex?
Yes, that is sort of exactly what I was angling for.
Okay.
And I think it's a great segue into what Isabel is going to talk to us a little bit more about. But first, I'm going to throw back to Michelle as well, because I think to what Diane was saying a little bit before this around sort of, you know, thinking about how systems work together, thinking about different ways of approaching problems and reconciling different ways of thinking. I think that is often a strength of what I call designerly ways of thinking, and which I distinguish from design thinking, which we don't necessarily need to get into. I think that's probably getting very jargony for everyone. But basically the ways of thinking that are used commonly in design research. And I'm wondering if you could maybe talk a little bit more about that. Oh, I think
You're on mute.
Yeah.
Sorry, are you directing that question to me?
Yes, sorry, and I got very rambly with it. So I was curious what
Yeah.
your thoughts are on what design has to offer in terms of reconciling with complexity and sort of negotiating how things work across different social, political, organizational systems.
Well, I think that design is about complexity itself and understanding that complexity, right? So what we try to do, well, what I try to do in my research, I don't speak for everyone in design because obviously there are many different design disciplines, theories, approaches, is I really focus on critical co-design. And so that's how I get at the complexities and the nuances across different stakeholders, audiences, different environments, et cetera. But what I've been finding in the individuals that I do research with is that co-design has been co-opted very much as the term design thinking has been co-opted as well, right? So I think you have to be really specific and define what it is. So for me, critical co-design has its roots in community-based and participatory research. And this is how you get at the differences and you are able to deal with the different stakeholders. So it first starts with a piece of being reflexive. So where are you starting from? What are your worldviews? What are your assumptions? How do you interact compassionately with those that you're doing work with? How do you interrogate your power and privilege? And how do you make time and space for sharing, dialogue, and meaningful co-creation? And also, what should you be doing? So how would you purposely select a broad range of stakeholders and the perspectives and representatives? So you have to go wide to go narrow as well. So when I can give an example from my own research, and I'm sorry, I'm mindful of time, so I won't take too long, is that I did field work, 18 months of field work in Hamilton in low SES neighborhoods to understand the seniors' housing needs who are experiencing housing instability and homelessness. So I went really wide. And then after that, the second study that I did, which was a continuation of that, was looking at the gap between low-income individuals and housing instability and long-term care because they were going too soon. So you go wide to the various stakeholders, and then you go narrow to address a specific particular question. And also you have to be mindful of your intended outputs as well when you're doing critical co-design. So I'm not sure if that quite answered your question because I started talking about co-design, but it's very important to be reflexive, to be intentional, and to spend the time in the long-term engagement when you're doing critical co-design.
Great. And I'm wondering, can you just spend you got a couple minutes left. So could you maybe spend a little bit of time explaining what you mean by critical, by reflexive methods? Because I think those are really central to how analysis works in design to me as well. But I think they're something that can feel very alien when you're coming from a different discipline.
I think it depends on your discipline. Anthropology is a discipline that does that fairly well because, I mean, as we all know, it has a colonial past. And it spent a great deal of time, quite a few decades, looking at its part in colonialism, how to decolonize the discipline, who you are as a researcher, where you're coming from, what your biases are. It's not that people don't have biases, it's just that you have to acknowledge them and understand how they would interact with your participants or your stakeholders or whomever you're doing research with. So that reflexive part, you have to know yourself to do this kind of work, especially if you're doing work with vulnerable populations who are unhoused or having housing instability. You can't stand up in a room full of people who have experienced trauma and not be authentic because people will know, right? They will pick that up right away and not take part in your research. And that's one of the reasons that it can be very difficult to deal with certain groups if someone hasn't done the work to be reflexive and know where they're coming from and understand how those particular pieces of your intersectionality will interact in the field, it won't go well in terms of long-term engagement or long-term relationships. So yeah, you have to look at what your worldviews are, what your assumptions are, what your values are, and what are you really trying to do? And you're not driving the bus in critical co-design, your participants are driving the bus. I hope that helps.
Yeah, that's amazing. And I love that we've circled back to relationships and especially sort of trauma-informed practices, because I know this is something that, Isabel, you spend a lot of time sort of trying to teach health researchers how to do better. And I think, as a patient partner and researcher myself, whose work focuses heavily on disability design, health justice, I found that there seem to be three big reasons why why researchers avoid doing patient or community engagement. And I mean, this is obviously a very broad generalization, but there are the researchers who simply don't want to do it, and that's its own case. But then there are also the groups that I find really interesting, who, they're also not mutually exclusive, but these are researchers who really care deeply about equity, and they either feel like they don't have the time and resources to do engagement well, and they're afraid that if they can't do it well, they're afraid of doing it wrong and doing harm by doing it wrong. Or they're hyper aware of the fact that health research historically has a problem with being extractive and exploitative towards its subjects, particularly when those subjects are from marginalized or oppressed or vulnerable communities. And I think in both cases, I've noticed this can lead to almost like avoidant tendencies, where there's this idea of, well, if we can't do this perfectly, we're better off not doing it at all. And I kind of want to trouble that notion a little bit too, because no one is ever going to be, we've been talking about complexity. We work within sort of constrained systems. So I think it's important to talk about how can we do it non-harmfully when we can't do it perfectly. And so I'm curious to get your thoughts on this, Isabella, and how you think researchers can get past these barriers.
Now, I know I have a time limit to talk about this,
So
but these
you've
are
got
some,
about 10 minutes. You've got tons of time.
okay,
I
super
can give you a
duper.
ping too when you're getting close.
Because I have a lot to say about this because it's the work that I do and it's how I've been harmed. I've had a lot of experiences with it. I'd like to kind of address these different groups and how I've come across it. The folks that don't want to do it shouldn't do it. They should be nowhere near patient partners, and that's fine. They shouldn't have access to the funds that require patient partnership, and they can go do their own thing. But pushing them into it when they don't want to is 100% of the time going to cause harm. It's going to be bad research because they're not going to get the right people in there. And we should just say, stop, just stop. Don't want to do it, go away. The other two groups are really interesting. There was a study that was asking pediatric pain trainees if they were interested in working with patient partners, if they'd had any experience in it, and if they planned on doing it or whatever. And it was a huge, overwhelming majority that was very much interested and wanted to do it. And then also the same on they didn't feel equipped to do it well. And I think that's just really typical. I think it's interesting that it focused on trainees because the same thing can be said for early career, mid-career, late career researchers. If you haven't been doing this, it can be a really scary thing to get into. And if you're coming from a positive place of actually wanting to integrate that knowledge and team members, I understand that it can be quite scary. And especially, I see this a lot in clinician researchers, but across the board as well, where their positionality isn't going into these roles because they're caretakers, because they want to help people. And that fear of harming instead of helping is a real thing. So yeah, absolutely, that is a huge barrier for patient partner research. But there are solutions, and some of that is, like Michelle said, thinking about, taking a reflexive approach to the work. So for folks that don't feel like they have the time and the resources, that's a really good thing to acknowledge, because doing this work does require resources and does require some knowledge. So the question is, can you access that knowledge in another way? Is there another professional like me, or are there courses you can take that can help you feel more comfortable with it, or that can offload that part of the work? How can you create a patient partnership plan that integrates with the resources you have? And, I'm here making trouble saying, if you're not allocating resources to this and this in general, then you need to think about where to pull that from in your work, so that a portion of it, and there's a huge amount of work that needs to happen with funders to be able to fund researchers at any stage in working with patient partners, because that's not done right now. And so people are kind of scrambling for funds or applying, there are grants, but it really should be part, if we want people like me to be part of health research, we need to find a way of paying for it, and paying for it in terms of compensating us for our time, but also having resources on board so that it can be done well. We all have different specialties. I don't know anything about statistical analysis, but I know a whole lot about patient partnership. So we have different people on teams to do the work well. So there are resources out there, and it's good to know, whether you have the resources to do the work. But then if you don't just give up. Like there are things out there. I also come across a lot of, I work at a lab, a pediatric pain research lab, and my role there is to kind of promote best practices and come up with resources, and but mostly to mentor the trainees and staff on how to do the work. And there's so much fear because doing patient-partnered research can look and feel different than not, and it's not taught how to do this. This relation, when you think about it, it's really basic being a human stuff, right? But it's not how health research has been framed or has been taught. It's a little messy. Finding the right patient partners and engaging with those communities can feel like you don't have a way into it. And what I tell a lot of people is, if you're a genuine human being going into it, understanding that you make mistakes, and there's no, I feel so badly for these trainees because you go through this academic, right or wrong, you have to have certain deliverables, that kind of thing. And then patient partnership is like, hey, make sure it feels good. It can be really, really uncomfortable. And we all must make mistakes, as a patient partners make mistakes, as somebody who works with patient partners, I've made mistakes. And you kind of have to embrace the discomfort and the messiness and the fact that you will do things wrong. And, the patient partners, I'm going to say all of us, because I think it's all of us. Maybe there's two people that don't agree with me, that we come to this work because we've gone through traumatic experiences and we don't want others to do it. That puts us in an incredibly vulnerable state when we work with researchers, because our desire, our need to make sense of what's happened to us makes us say yes to things that we shouldn't say yes to. So for researchers to understand that, I find this difficult for trainees because they're not used to being in a position of power, and they are. To understand that can make us make choices that we'll regret later. So to kind of create a space that allows for mistakes, that allows for different ways of speaking and being. Everybody says, you got to put another chair at the table. Get rid of the table. The table is dumb. I don't want to go to your stupid table. I want to go to the coffee shop. Let's go for a walk. We need to reimagine how we connect with people in a like really basically human way. And that allows for forgiveness and for saying, I'm really sorry. I should have done this. I should have communicated earlier or better or differently, and I didn't. I'm sorry. How can we make it better? And that's so hard. That's so hard for any human being. But that's what starts to build the trust, is in being that human that can admit mistakes. And then what continues to build the trust, and I'm just thinking of different places and opportunities that I've lost trust, is when working with patient partners, it's not about listening or making them feel listened to. Psychologists love it when I tell them to throw away the feeling language. it's about what actions are you undertaking as a team lead, as a member of the team, to um, to believe and respect the knowledge of patient partners. We have our own lane on the team like everybody else does. And then, even though it might be scary, to integrate that. And it's that piece of bringing us into the work and having the humility to maybe change the work. That's the biggest trust builder. And that works for like everybody from communities that haven't been listened to. You know, we're not vulnerable, we're ignored. You know, so to actually be listened to is a huge trust builder. And again, there are resources on how to do this well, but I really think it's a lot of it is forgiving yourself to make mistakes, to be a human being, and to take the time. The time thing is so hard in health research. Everything kind of goes like this until it goes like nothing, and then it goes like this. And that's not great pacing for relationships. So finding ways to overcome that is really important.
Thanks so much for sharing that, Isabel. And one thing that I want to make sure sort of everyone caught was this mention about sort of moving away from feelings language, because I think that is an issue with sort of so-called patient-centered care and patient partnership beyond just psychology. There's, you know, the way in clinical practice, there's sort of the so-called hierarchy of evidence, and in their attempt to, you know, incorporate shared decision making with patients, they've sort of brought in this idea of patient beliefs and preferences. And I think like it's really important to hone in on what that does to position beliefs and preferences in relation to evidence, because I don't think that was necessarily meant that way, but it subordinates one to the other, and it still makes one of those seem less, you know, less objective, well, I mean, it is less objective, but it makes less objective seem less rational and less valid.
And that's how we talk on teams as well, right? Like, well, with the patients
Yeah.
here to tell their story.
Yeah.
What does the evidence say when the academic brings that? That's such a hierarchy of whose voice is important. And this is why like I encourage and people that I work with is to move away from, I mean, our expertise comes through our stories, but honestly, it does from the academics too. Their stories come from published literature and what other people think of what they wrote. Like it's all stories or it's none of it's stories, right?
So, you know, I think we could spend at least a full hour talking about the practical and systemic challenges that exist to doing meaningful interdisciplinary and community collaboration within our health research ecosystem. And I know, like you alluded to, I think one of the most important ones, which is just time. But given that we only have a little less than 20 minutes left, and we do want to save some time for questions from the audience, let's talk about what researchers can do right now. So I'm curious from each of you, and I'll start with Diane. What is one piece of advice you have for early career and trainee health researchers who want to start working on, you know, actually acting to intervene into social determinants of health?
Really rather give advice to the funder, actually, if I can, because one of the things I couldn't help but think about while you were talking, Isabel, is how badly funders understand the paradigm under which this can happen. So, you know, if we think about the traditional funding paradigm, it's propose something 3 years before you're actually going to accomplish it. We'll get through the review process. You said you're going to do this, and then you have to show that you did it. And there's no time, and you have to say what you're going to do before you've actually undertaken that co-design process with your patient partners. And so how can you say what you're going to do with any veracity if you haven't done that work? And so what did funders do early on? They said, okay, well, we'll have convening and collaborating grants, or we'll offer stage one, and then we'll have a competition for the big money. And I can't forget the story I heard from a clinical researcher who had really embraced the idea of working with patient partners, co-designing the work, really doing a lot of investment in time and energy because there was a stage one, and they didn't make it to stage two. And the patient partners wanted to know what happened to all the work and time and energy they'd put in. They'd made a commitment, and the funder didn't make a commitment back to allow that work to happen. And so I think we really have to think of other ways in which to enable and support real co-design that's iterative, that allows us to make mistakes, that allows us to talk about how we fixed the mistakes, right? Like I have a really strong predisposition to thinking that we've got to change the granting system from say what you're going to do to say how you what you learned from the most recent experience and how you're going to fix that. And I tried actually to do that when I was president and CEO of the Michael Smith Foundation here in BC. And we had a peer review of critical friends, if you will, for a large investment in Foundry, which is a youth mental health service here. And then I left Michael Smith under duress. And in the end, I don't think it got to keep going. So anyways, I know you asked me about researchers, but I couldn't help in listening to Isabel that we really need a message to funders to find better ways. So it's not all the researchers' fault that they can't do this in a good way because the system doesn't let them.
No, I really appreciate you sharing that perspective, because honestly, like that is what I spend a lot of my own time railing against, the number of emails I've sent to my collaborators complaining about how our granting system works. And I think it is important to remind, like we're talking about structural and social determinants. This is itself a structural determinant. It's not an individual problem that researchers just aren't doing it well enough. So thank you for calling that out.
Thanks.
I'm gonna pass to Michelle next.
Sure. I have a very practical view of this because I agree with both of you that the system isn't designed for meaningful co-design in terms of funding. But a couple of practical things. So if one is doing phased research, which co-design should be, before you start it, map out what the funding landscape could be like. So each little step that you have to go along the way, what you need to apply for to make sure you try to have some sustainability. You don't always get them, but sometimes on the second try, it's more successful. So when I would meet with participants, I would let them know what my funding was and what the trajectory was or wasn't. So managing expectations is also really, really important. Like I like to do meaningful work, but I don't want to promise things that I cannot deliver because that doesn't work long-term for relationships. So I try to find other ways to give back if I'm not 100% sure what the next phase will be funded or when it will be funded, because sometimes there's a time lag. I'll try to find some other way that the community feels that there's been a benefit to them. Often having their stories heard and taking part in co-design, especially arts-based co-design, and the sociality attached to that is really meaningful for participants. But it can range from anything from technology training. I've done research on iPads with adults, giving them access to technology. There's other ways to determine at the beginning when you're building the relationships what their needs are in the community. And so try to meet that on an informal level and then try to plan longer term and manage expectations.
Thank you so much for that practical advice. And Isabel, I'm gonna throw to you as well. What are your thoughts on this?
I'll try to be brief. One of the things that I keep saying to especially new people to this work, or people who think they understand what patient partnership is for, by people I mean academics and professionals, is that my trauma isn't there to make you feel something, whether that's pity or whether that's some kind of alliance with me, or whether that's to feel why you continue to do this work. My trauma isn't there for your feelings, and the knowledge that I bring comes directly from trauma. The way you speak about how you work with patient partners, both to patient partners and about your work and your applications, your language can either lift and respect our contributions, or it can keep us as there for feelings and not for work. And so I really encourage people to think about how they're talking about. Do they talk about patient partner stories? Do they talk about expertise? Do they talk about team members? Do they talk about if we're actually partners in the work, regardless of the role that we bring or how much we bring into it. I think I think language can influence how individuals see themselves, how they can see coworkers, and how observers can see how something is working or not working. And I really encourage people to think about that. Yeah, I'm going to leave it there.
Amazing. So we have a few minutes left for Q&A, and I see that we do have a few audience questions. For me or Isabel, I'll throw to you first, Isabel. Is there a project you've been part of or observed where co-design was done especially well, and what made it work?
That's such a good question because I've been in some absolutely abysmal co-design situations, and I've been in a couple that have been wonderful, like really, really wonderful. And there's a lot of frameworks for all kinds of things out there, whether it's co-design or patient partnership or implementation or whatever. And most of these frameworks were created, like patient partnership is changing like by the minute in terms of best practice. So most of these frameworks don't have space for best practice with patient partnership. So where it's gone well for me is where either myself or another expert in patient partnership was there as part of the team designing the co-design opportunity so that it can be modified with our better understanding of trauma, of expertise, of all these things that we work on. And in those two projects, I'm thinking specifically of two projects, the influence of the patient partners in the work, as well as their comfort with the work and support for them, created something really robust. And from a participant point of view, talking about things that went badly is really, really hard. Talking about things that went badly for your kids is where they're traumatized and have lifelong effects is a pain I don't wish on almost anyone. I'm not good enough to say everyone, but when that's used for something meaningful, it lessens the trauma, or at least makes it worthwhile. I hope that answers the question.
Yeah, I think that's great. And I'm gonna take maybe a slightly more provocative and theoretical tack in answering it, which is to say that I have worked on projects, and I am working on projects that I think are doing patient partnership incredibly well, and that are giving me the freedom to do the design research part of things in the way that I believe it should be done, which I really appreciate, and I'm really excited to see where things go. And I think that broadly speaking, co-design is not well done when it is done in health research context, because I think we are lacking. I think when co-design is taken up by health researchers who lack an interdisciplinary background, we've sort of alluded to this problem already, but it's that analyzing things as part of design research, as part of doing design, is a fundamentally different way of analyzing things than we do in health research in STEM. It involves this practice that we've sort of been talking about called reflexivity, which is really like critical reflection. It is questioning your biases and assumptions. It is questioning how the things you are observing exist not only on their own, but in relation to a system, but also how you are shaping what you are observing because of the position from which you're asking the questions and the way that you ask the question and the background that you brought into asking that question. And that is all a really crucial part of design that I don't think I don't think that most health researchers who are doing what they call co-design realize that I want to say the most important part of co-design is that, because the actual engagement and meaningful collaboration with the sort of subjects of design, which is sort of a gross way of saying it, but the participants, the community collaborators, the people you are designing about, actually engaging them as collaborators rather than designing about or for them. That is an important part, but equally important is what it means to design, which is that process of criticality and reflexivity. And I feel like I'm throwing like all the words that you know, it made my brain swim when I was in my first semester in design school. But like those are really, really important concepts to sort of wrap your head around if you want to engage effectively with design. And then I think too, I want to call out a comment that that Kate shared in the chat. Sorry, Dr. Kate Sellen, who's from OCAD University. And she pointed out that co-design as a paradigm, as a methodology, is really grounded in storytelling and in feelings. And as such, it can be limited in capturing certain types of experience and responding to certain types of problems. And I really like, Michelle, that you've talked about critical co-design, because I think that's a necessary expansion of it. But I think we need to think about too how people often aren't given the language to talk fully about the experiences they've had when they're oppressed. Like often that the reality of being oppressed is denied to them through medical gaslighting, for example, or through literally having their language taken away in the case of colonialism. And also, you know, having the emotional and psychological, if we're talking about feelings, having the emotional and psychological safety to be honest about your experiences. There's a whole other dimension behind that. And so often we say that we're talking to patients, to community members, that we're engaging with them, that we're partnering with them. And yet, are we doing that work under the surface to ensure that we're actually surfacing truths and power dynamics? And again, that goes back to the reflexivity. Reflexivity is questioning, am I creating space to actually get at those truths? And what are the ways in which I might be sort of obscuring some stuff? So we've got another question from the audience, which is, please could you share some tips on how researchers can best invite feedback from patient partners about what is working or what is not working? This audience member, it's Dr. Claire Ardern, says, I was thinking of things like when, how, through which avenues, how frequently, etc. So not trying to limit that convo of inviting feedback. So I'll throw that out to anyone who has thoughts.
Well, you know, I have thoughts. Everyone knows I have thoughts. So I'm a little, I want to make sure I understand the question, that this is feedback for patient partners you're working with to make sure what you're doing is being done in a way that's comfortable and safe and all that kind of thing. Assuming that that's it, has a lot to do with language and has a lot to do with how you frame opportunities and what you're doing. It can be very intimidating, especially for people who are less obnoxious than me, but even for me, to say to a researcher, and also they may not know because they might be new to it, about what's going wrong. There can just be kind of a feeling of discomfort, or always feeling that that they don't belong. And you really have to ask explicitly, like you have to be uncomfortable and say, you know, ask the questions that could give you the answers you don't like. And even suggest that, hey, I know that this can be done wrong, and I really want to know how I can improve that. Creating that trust relationship is a huge part. If you're actually integrating their experience into the work, that creates the trust that we can say to you, emails don't work for me, you know, says every youth I've ever partnered with. So yeah, it's really kind of being honest about that and being prepared to be uncomfortable for bad news.
Amazing. Thanks so much, Isabel. And with that, we are very close to time. So that wraps up the service design in health research webinar today. We hope that you enjoyed learning a little bit more about how to think about design and co-design and criticality and reflexivity. Thank you so much to everyone who attended today, and especially to our speakers. I don't know, I feel like I learned some stuff, and I do this work every day. So I really appreciate you all. Thank you so much.
Thanks, everyone.
Thanks for having me.